Hello, everyone, and thank you for joining us for MOASC's Researcher of the Month video chat today. I'm very delighted to present Dr. Bartosz Chmielowski from UCLA, clinical professor of medicine. My name is Ashkan Lashkari, MOASC president, and I'll be interviewing Dr. Chmielowski. Thank you so much for being with us.
My pleasure. My pleasure.
Well, I know that you've had a lot going on in terms of your work within cutaneous malignancies as well as within sarcoma, but I wanted to just have you introduce yourself and kind of tell us what your areas of clinical interests are right now.
Yeah, it is a great pleasure to talk about my research interests. So for the last 18 years, I've been studying melanoma and doing clinical research in melanoma. And we started with early immunotherapy clinical trials and targeted therapies. Luckily, these therapies are currently available for patients. But still, there is a significant area for improvement even in the treatment of melanoma. So although PD-1 blocking antibodies and combination treatments are definitely breakthrough, at least, half of the patients, not two-thirds of the patients will develop resistance. So we still need the therapies that can overcome the resistance as an addition to the first line or the subsequent lines of the therapy. So we had a significant improvement in overall survival with a median survival less than 12 months in the past. Now we are talking about the range of 5 to 6 years as a median survival patients with metastatic melanoma, but still there is an area for improvement. In addition, in melanoma, we put a significant effort into pushing the therapies into earlier stages. So we already have several agents that are approved for the adjuvant setting in stage 3 melanoma. Recently, pembrolizumab was approved for stage 2B and 2C melanoma. And more importantly, we start developing, or we've been working on development for the last 2 or 3 years of neoadjuvant therapy in stage 3 patients. As recently we published a paper in New England Journal of Medicine describing the use of pembrolizumab in the neoadjuvant setting in patients with stage 3 melanoma. It's a breakthrough paper in this way, not necessarily, because both groups of patients in this clinical trial received the same type of therapy. One group had 3 doses of neoadjuvant pembrolizumab followed by surgery and completion of a total of 1 year of adjuvant pembrolizumab. The other group went immediately to surgery followed by 1 year of pembrolizumab. So at the end, everybody is getting the surgery and the same number of doses. But it clearly shows when if you do it, to give at least 3 doses of pembrolizumab before surgery, we had a 20% improvement in event-free survival. So this trial is one of the first trials showing when it's not only important what you give to the patients, but you have to think about it, about the sequence. Sequence may have a significant impact what's happening to the patients. So we have efforts, right now to say, should we do people need the whole year of adjuvant therapy? Maybe less. If we gave them in the neoadjuvant setting and they had a complete response in the resected lymph node, how much do they need afterwards? What if we try to use combination therapy before we take the patient to surgery? So these are all important questions, which, this is something what we develop in melanoma.
Go ahead. Go ahead.
No, I'm listening.
I was just going to say, no, the work was definitely groundbreaking. I think all of us who treat melanoma patients are going to be, incorporating this new standard right away. So it's amazing work. It's also amazing to just see how quickly the field of melanoma has changed in the last 10 years. To even think about neoadjuvant therapy as a way of treating these patients was somewhat radical, but we're here.
Yeah. So now, what are the interests, what are we working on, and what's important, for the field of melanoma? As I said, many patients develop resistance to the therapy. And so we need subsequent lines of the therapy. So I would say it would be naive to think that everybody has the same mechanism of resistance. So what it means, it would be naive to think, oh, I can come up with one single drug that will address all the patients who became resistant to PD-1 blocking therapy. That's why we try to address and look at the different possible therapies. And this week, or at the end of the week at ASCO, we are going to present a data on, for example, on new injectable drug, RP1, when we had a large cohort of patients with melanoma whose disease progressed on PD-1 blocking antibody, and they received RP1. So the data will be available, I think, on Saturday. And so hopefully, this may lead to additional therapies, that will be an option for patients with melanoma. And what's important, the drug is injected not only to easily accessible lesions, but can be injected also to visceral lesions, which is somewhat new, and the drug is well tolerated. Also, we say, okay, maybe we should target the B cells. So again, there will be at ASCO an oral presentation about a new tumor-specific antibody called ATRC-101. And this is an antibody that was isolated from the patient who had a good response to nivolumab, is a patient with non-small cell lung cancer. What we see when as we have responses to PD-1 blocking antibodies, at the same time we get a B cell responses with a short-lived increase in the number of tumor-specific plasmablasts, and you can isolate these antibodies and then make it in a clinically available antibody and use for clinical trials. What's interesting in this drug, we saw responses in melanoma, but this is not necessarily melanoma specific. As long as the target is present on the surface of tumor cells, can be used in other malignancies. So hopefully this will help, and branch out to other malignancies and not gonna be melanoma specific. There is still a significant interest in development. We have in development new cytokines or modified cytokines, and this would be new formulations of interleukin-2. High-dose interleukin-2 remains approved for patients with melanoma. It's associated with significant toxicities. Right now, there are modifications when target not all IL-2 receptors. Because of that, they can spare patients from toxicities, or the forms of IL-2 that are only activated within tumor environment rather than everywhere in all peripheral tissues. So there was a little bit of disappointment with bempeg-aldesleukin, which is a pegylated interleukin-2, and the larger trial was negative. But there are other efforts. We know that IL-2 can work. Can we make it less toxic and more active? So the future will show. As we know, also targeted therapy is important. So it's not only immunotherapy, but for patients with BRAF mutated melanoma, but unfortunately they still develop resistance, or a small number of patients may not have a typical BRAF mutations. They have so not the typical V600 BRAF mutation, what we call type 2 or type 3 BRAF mutations, and these patients would not benefit from the treatment with a traditional BRAF-MEK inhibitor. But we are developing new pan-RAF inhibitors that have ability to inhibit not only a BRAF isoform, but also a CRAF isoform, and can have activity possibly in this atypical BRAF mutated patients, or with a typical mutation but resistant to previous therapies. Also, these drugs have a possibility to have activity in NRAS mutated melanoma, and NRAS mutation is the second most common mutation after BRAF in melanoma. So we will see where it pans out. We are involved in one of the drugs. There are several in the market, or several in development. So I mean, these are kind of an exciting fields. We are trying also to work on what we call bispecific antibodies. They can target either, LAG3 and CTLA4, LAG3 and PD1, or for many, many years, I've been working on targeting a molecule called B7H3, and we had early trials. Now we have antibody drug conjugates that target this B7H3. It's a molecule that is expressed on most of melanomas, but not only on melanomas, it's expressed on prostate cancer and other malignancies. So this might be, again, an option to develop a treatment which is not only melanoma specific.
Well, this is very exciting. It sounds like there's a lot going on in melanoma, as there should be, since, as you said, there's still a room for improving the quality of our patients' lives and, of course, their overall survival. I just wanted to thank you so much for joining us today, and I wanted to make sure that we include your some of the clinical trials that you have ongoing supporting the investigation of some of these agents that you mentioned. They all sound very exciting. And of course, we're looking forward to even newer breakthroughs within melanoma. So thank you so much for joining us.
Thank you so much.
Bye-bye.
Bye-bye.